electronic care record as an enabler of system transformation. And really lucky to be joined today by Dr. Dermot Hughes, who is the Senior Responsible Owner for the Encompass programme. Now, as you'll know, Encompass is set to really transform health and social care in Northern Ireland. And we're introducing a single integrated healthcare system. But beyond the technology itself, the programme is about real change. It reshapes how care is delivered, it's going to improve patient outcomes, and support staff with better tools and information. So in today's session, Dr. Hughes will share some insights on the transformation that Encompass is and will continue to enable. But also how the team has approached business change and change management throughout the programme, which is a big enough task in itself, given the significant change that Encompass has introduced. So I will hand over to Dermot now. As I've said just before we started recording there, please pop your questions in the chat. Please keep yourselves on mute and enjoy the session. And yeah, Dr. Hughes, if I hand over to you now, please.
Thanks very much, Tom, and thanks to everybody for inviting me here to give this talk. I will just bring up the slides. I'm the SRO for the programme and have the privilege of doing this for coming up to 3.75 years, nearly 4 years. Next slide, please. Yeah. I need to thank people who came before me for their vision and foresight. The implementation in Northern Ireland is quite unique, and we'll talk about that in a minute. But what is an electronic care record? It's a lifelong record for a patient, and what we're trying to do is standardise the health and social care across Northern Ireland between 5 trusts to make sure that it's the best practice delivered everywhere. The really unique and piece of this programme is that the electronic care record covers secondary care, mental health, community care, social care and social work, and I should say prison health. That's unique to Northern Ireland, and when I say unique, it's unique in the world, and that was decided by the people who drew up the business case initially in 17, 18, 19, and that's really ambitious, really wise, and will deliver many benefits. It means that Northern Ireland is in a place to deliver more than could be imagined elsewhere, certainly within the UK and Europe. It means that patients will have access to their own information through a portal, and we'll talk about that. But it will improve access to care, improve patients' experience in care, and reduce risks and improve outcomes. It also does a different thing. Culturally, it changed the care dynamic. We have to admit that care previously was delivered possibly in a patriarchal way in Northern Ireland, and care was delivered on to patients. And it's really important that patients are partners in care and have some responsibility for their care. So if we go to the next slide, please. Why? The electronic system in Northern Ireland has about 70 digital systems, many of which do not connect together, and there's system duplication. But many of the systems are near end of life. So that was the imperative. Inpatient and work is currently largely done on paper, which is a clinical risk, and it's information that is in silos and cannot be easily accessed. We've mentioned the fact that many digital services are nearly out of life. But as we're well aware in Northern Ireland in terms of healthcare, in terms of multiple recent public inquiries, oversight and governance of the healthcare system is really problematic and difficult. It's a complex, multifaceted system, and nobody has a single oversight with an electronic care record covering all patient journeys. So we will have solved that problem. We've talked about variation in care. The variation in care is not only a clinical risk, but it leads to cost in the system and unnecessary cost in the system as part of the go live with step through 5 trusts. And you can see that people do things largely in the same way, but multiple different variations. That's difficult for professionals working in the system and adds cost. And we've talked about the fact that patients don't routinely have access to their information and data. So you can't ask patients to be responsible for their healthcare if they're not partners in the information about their healthcare. And then digital care enables radical transformation, and we'll talk about some of the radical transformation later on in the talk. The things I'll be talking about are not tomorrow's world stuff. It's things that are already being delivered on the Epic platform elsewhere in Europe and America. Next slide, please. Okay, these things you probably know. We have a population growing to about 2 million. We have 6,000 beds. We have a budget of 7.5 billion. I think the important thing about the budget is that it's over 50% of the gross national product, and it'll be difficult to stretch that budget further. So we have to get more productivity in the system. The word productivity is a sort of difficult one in healthcare, and what we really mean is making sure more people get access to care they need for the same amount of money. We've over 80,000 staff when we add in locums, bank and agency staff. And we have to link with 320 GP practices, 368 dentists, and 528 community pharmacists. Next slide, please. Okay, and these are the figures for domiciliary care. 500,000 domiciliary care visits. We have 1.5 million outpatients, 18% of which are virtual. The figure's slightly higher, but it has decreased somewhat as COVID waned. We have over 250,000 inpatients and going close to 300 day cases. So this is a big healthcare system, a very complex healthcare system, and one that had no oversight on a conjoint electronic care record. Next slide, please. Okay, this is our journey to date. The business case is pre-21, and we did some initial work. The WAFWT means workflow walkthrough, and that's where we took all the patient pathways in Northern Ireland and got the staff and multiple trusts to review them and standardise them against best care. And that's a unique process for Northern Ireland because we're ensuring that care is delivered to the same quality irrespective of geography, and that's a big achievement from the staff, and we'll talk about how we did that. We've developed the system, and we're currently coming up to, we've done go lives in South Eastern Trust, Belfast Trust and Northern Trust, and I'm actually speaking from the Western Trust. We're preparing a go live 90 for their go live, which will be actually on the 8th of May. So next slide, please. Okay, what are we buying into? We're actually buying into a family of services on the Epic platform. Once you buy into the platform, you're buying into what they call a foundation system, and that's built on the work of others. So you can link with the knowledge and experience and past work of all the other partners. I have very close relationships with our UK and European partners because their healthcare systems are similar, but we can reach out around the world. Just to re-emphasize that we are a very unique Epic implementation, that we are now having people reaching out to us from Quebec, New South Wales, and the Republic of Ireland and mainland Europe to look at our implementation in regards to social care, community care, and mental health. Next slide, please. So who did we do? There's 310 technical staff at the peak of the implementation, which reduces to 119 for 13.5 years of the program. We funded 205 trust staff to support the go live. We had 5,000 HSE staff doing the workflow walkthroughs to assess the pathways, and 3,000 staff who actually defined the agreed regional pathways. So it's huge numbers and huge commitments. The 205 staff was an increase from the original business case, recognizing this is not a technical implementation. This is clinical and social care transformation delivered by trusts. So in 2021, we had to recognise that by an addendum to the Department of Health and Department of Finance. So it's a case of a large transformation business case, which really didn't call out all the problems, and the business case had to evolve as the programme went along. Next slide, please. Okay, so what have we done so far? We've trained 12,000 staff in the South Eastern Trust, 26,000 staff in the Belfast Trust, and 12,000 staff in the Northern Trust. I mean, the training is between 1 and 2 days, and it's supplemented by what we call user labs. So in the Northern Trust, we put on 14,000 placements for staff to do additional training. So this is high-end, high volume, complex training, and the training is not one size fits all. It is specified to the individual job that a patient or professional does. So it's not nurse training, it's perhaps an infection control nurse training, or it's a cancer nurse training who does clinics and maybe gives chemotherapy. So the training is very bespoke and very targeted around patient need. We're currently in the process of training another 20,000 staff in the South and Western Trusts. In essence, we'll probably train over 80,000 staff across Northern Ireland. Next slide, please.
Hi, Dermot. Apologies. My computer is going to update in 2 minutes, but Darren Mercer, my comms officer, is going to just share the screen on the slides that we're on, thank God. Darren, if you could just share, I think we're on slide 10. Thank you so much.
Okay. These are the groups we defined regionally, and you can see there's cardiology, there's dental, there's dermatology, and these are what we call e-design groups, and these would be the groups that look at the overarching areas, and the ones in the green are process groups. So it might be bed planning, it might be data and governance, and this is the baseline foundation of the transformation work we're doing. If we go to the next slide, and you don't need to look at the details, the next slide goes into what we call the focus design content groups. So there's 140 of these where we have to draw out the pathways of individual every service of care. So we've done this radically across Northern Ireland and standardized our processes. This flows upwards to a governance process, which is, the next slide, please, it's all encompassing and hence the name. It involves professional groups, nursing groups, pharmacists, social workers, but it also, in a parallel process, each individual trust has a similar encompass readiness group and an encompass program board. This goes to the delivery readiness group, which is populated by directors of performance and planning, clinical leads, and trust members, and eventually up to the program board. And the program board contains all chief executives, DHCNI, BSO, basically all major players in the health system. And it's about having sight of all governance issues, sight of all risks, and making sure that we have governance and mitigation of risk. It's a very complex piece of work, and it has evolved over 3 or 4 years. It's never perfect, and it's constantly in evolution. And that's the sort of skeleton we work from. And I'm now going to talk a wee bit about the culture behind that skeleton, because you can have any structure you like, but if it's not the appropriate culture, it will not succeed. So we talk about culture. Now, what is culture? And I think it's a kind of vague term, and it can be self-defining and defined in different ways across the patch. So we regard it as a set of behaviours which are agreed and managed between all partners in this implementation. We're very keen that this is an implementation delivered by Trust, enabled by Encompass and their partners in the DHCNI, the Department of Health, BSO. So we one of the issues about when can we go live, can't do it at winter time, can't do it post-COVID. We've had to recognise there is no perfect time. And in essence, the health service is so stressed, there is no such thing as a perfect time. The other thing we talk about, culture, this is sort of a bit of philosophy. A rational man is never too sure of himself. And I think that's about making sure that we don't overpromise and underdeliver, that we always have that voice in the background saying, are you sure about that? Is that correct? Is that safe? How will that affect patients? Can we deliver that? So when we go through our process, and we have shared governance, we have shared mitigation, and we've shared ownership of risks. We do that through a go live process, which happens at day 150, day 120, 90, 30, and etc. And we do that with Trust in partnership, but we can only do that in a meaningful way if we are true partners. Have your own why. Health services, 80,000 staff. It'd be illogical to think everybody's an IT zealot and is really keen on electronic healthcare records. That they have to have their own why. So if you're a nurse in the ward, we have to be able to tell these people, look, this is what it'll do for you, this is what it'll do for your patients, and this is what the future is. So you need to tailor your stories for those that are receiving the change and actually are delivering the change. buy-in through relationship selling. I'm not trying to sell sort of snake oil here, but you do have to have a relationship selling, and that's either with your vendors or your users or the people who are about to do this work for you. So relationships are really, really important because sometimes you have to have difficult conversations, but you have to be able to have those conversations where people do not take offence or where we do not take offence, and we know that it's focused on delivery of safe care. Pay it forward, pay it back. This is possibly something unique to our implementation. It's where people come from one trust to another trust to help them support their go live, help them to bring care back to normal activity levels, and basically we work across the province. So I'm going to go live, we're going to go live with the South and West in 8th of May, but we need support from the rest of the province. So we will get 500 professionals from Belfast, we will get 350 professionals from the Northern Trust and 350 professionals from the Southeastern Trust. These are people with knowledge, skills, experience, and ability, and they will keep the patients safe in the North and West. In the South and West. And I think that's quite a unique way of working in Northern Ireland, because previously we tend to be siloed in trust and a bit competitive as opposed to collaborative. The other thing we insist on in our culture is absolute candor. You have to be able to be believed, even if it's difficult stuff, and you have to be able to believe those that are talking to you. So we have to build a relationship and making sure that the relationships are built on absolute candor. Look, this is difficult stuff. This is stressful. And it's stressful for trust in the fact that while they're doing this delivery, that they're trying to manage winter pressures, they're trying to do a range of things. So we need to think about long-term pastoral care. So next slide, please. So it's one team. We risk assess on the basis of patient safety, implementation safety, and finance. Delays cost money. It's inclusive, and every member has right to impact and input into the governance, and they do so, and that's the strength of the programme. We fund specific posts and specific professionals to do this. We measure the governance by not by narrative, but by numbers. It has to be something that can be measured and mitigated. We're not trying to be perfection. We have to understand what good enough is, and when everybody agrees that the build and the training is good enough, we'll go live. Next slide, please. Okay. Next slide. Leadership. People ask what's about leadership. It's very clear that this is a program enabling others to do the work and others to do the delivery. So it has to be servant leadership. It has to be respectful. I don't mean servile, which is a different word. It means that you're enabling others to do this. There has to be mutual respect, and mutual respect that while we're doing a program, the people in the trust are doing the program and half a dozen other things. Again, I emphasize it's trust, deliver, supported, and enabled. A term you may not have heard is super users. We actually train 1 in 4 staff to be advocates and have a higher level of skills. In essence, the transformation has champions. 1 in 4 members of staff, irrespective of where they are, be they in admin, be it in porters, be a surgeon in theatre. 1 in 4 staff is, in essence, a champion for this transformation, and that reach and depth of professional leadership allows for the change. I think where transformation has failed elsewhere, it's somebody who's very keen on a topic, brings it back to a trust and tries to do it onto a trust. This is a quarter of the staff doing it themselves. So that leadership is at all levels. We manage the leadership through agreed data. Where there's problems and people aren't so sure, we're very quick to bring them to their peers elsewhere in the UK or elsewhere in other trusts in Northern Ireland to see that, so that they can see how it works for themselves. Often things go wrong, and I really do reference this a lot of times. When things go wrong or when we get wrong, make sure you apologise, because there's a strength in admitting, got that wrong, we could have done it better. And I think if you show that in leadership, you will get a lot of buy-in. So next slide, please. This is just a slide. It shows data-driven healthcare, and that could be near real-time data for governance, social determinants of health, and we'll talk. I'll go on to the next slide, given the pressure of slide time. Okay, this is our successful implementation so far. They were all different in their own way. South Eastern Trust, I think we'd have to acknowledge, was probably the hardest because it was the first. We were all very novel at this. Belfast in itself was a hard one, but really well delivered because it's a big regional centre. It's one of the biggest trusts in the UK. And the third one, the third one was delivered excellently, mainly by the Northern Trusts themselves, who had developed and expanded different ways of training and have had a very well prepared workforce. It's very interesting, the differences between trusts, but the successes and the catharsis of going live was a joy to behold. So next slide. Okay, and we're about to go live in the South and West. Next slide. Okay, we have to prepare staff because they're doing two things. They're standardized their clinical pathways, and they're going on to an electronic pathway. So the training is essential to make sure that patients are kept safe. Where we can't achieve all digitalization, we have mitigations in place for bridging periods of time. And we have to ensure that there are information and resources available for staff to understand the changes. Okay, next slide. Okay, this is a list of changes that each professional will see, and you can probably read them in your own time. In a ward, an acute nurse will be able to see data across. Some of the major changes are actually in community services, where people previously were out just with paper held notes. They now have access to the complete record of a patient that they're seeing out in the community. They will know the psychiatric history, they will know the social care history, and they can provide holistic joined up care. ED doctors now can see the social care background of patients and our psychiatric needs. So we've been able to transform the care delivered to patients and transform the experience of that care by patients. Next slide, please. Okay, the patient portal will be the new face of the health service. We've got we're going close to 100,000 users now. It'll be used for patients, and it means that they will get their own data, their own results, and will be able to communicate with carers. It's an extension of the platform. It's not just an app, so you can upload data and it can be used for at distance care, virtual consults, and healthcare at home. And we'll talk about that in a minute. Next slide. I'll let you read these in your own time. These are some expressions of thanks from patients who had care and were in care for a long time, but had never really had much insight into their own care. So next slide. Okay, we've put a platform in, but what are we going to do with it? And these, what I'm going to talk about now, are what other people in local jurisdiction in the UK and Europe have done with it. And these are functionalities that we currently have and we can turn on at any time. So FastPass is an idea where in your app, if a slot becomes vacant because of a no-show, that they can get patients into those slots. We have a do not attend rate of possibly 9% in some services. So if we want to maximize the use of our outpatients, our day case procedures, this is how to do it. MyCare scheduling, it means that people can take control of their own scheduling and their own appointments without the need of being a passive recipient of appointments that maybe don't suit them. MyCare questionnaires, part of our problems with the health service is that we don't necessarily know how to get feedback, or when we do get feedback, it's very small focal areas. The app gives you a chance to harvest information from wide numbers of people. The app can be used to get permissions for people to go on to clinical trials, etc. And it's a new way of communicating with patients. Number 4, in baskets, it means that patients can ask questions of their caregiving team, but we can use AI to help with those drafted responses. Number 5, please, next slide. AI chart notes summation. So what happens elsewhere, and say our colleagues in Holland are doing this quite a lot, where the the electronic platform will be automatically populated with information at ward rounds. It means that nurses spend less time tied to record keeping, and doctors or outpatients spend less time at record keeping. We'd like to get involved with ambient technology where you can have an unstructured conversation with the patient and it automatically populates into the electronic care record, and both parties receive a copy of that summary. The platform will do predictive analysis, so it will tell you who's likely to deteriorate, who's likely to come back to outpatients again or come back to ED again. It can predict those who are not likely to not attend at outpatients, so that can be allied to the fast pass functionality to reduce non-attendance at outpatients. We have capacity command centres, which is how you manage flow across the trust. We'd also like to link with the social care providers in the independent sector, so that for social care placements is one of the biggest problems in the health service, so that people can be moved into social placements at a much more rapid and appropriate way. We will have expected date of discharges from the day of admission, so those providing social care can and do provide placements on a much more timely basis. Next slide, please. We've talked about expanded care link. Sorry. Obviously, this can be for research and development. Our platform is unique in that it's cradle to grave, and it includes the social determinants of health, and it includes social care. That is a unique set of indices, and it will ignite the research and development in Northern Ireland. There's no question about that. And finally, this is while it's present in Europe and the USA, but not in the UK as yet. The Cosmos is where we have the anonymized records of 270 million patients. It means by searching this database that people with rare diseases no longer are part of a rare disease group. They have other comparators, and you can use the database to get advice on unusual cases and lookalike disease groups. So it's thinking that the platform provides the record, it provides the data for research, but it provides the data for much more in terms of quality assurance care given. Next slide, please. Data is really important, and this is a more open platform than previously. So these are some of the areas that we use the data in. I should say we are changing the assurance provided around data security. To date, information governance usually looked at data breaches when something had happened, and it's a retrospective look back. What we're doing is having proactive audit of the data on the system, so we can proactively audit those who are not members of the care team looking at a record. We can look at those who have accessed the care record but not made a note in the care record. We can audit those who've got a similar name to the person in the care record, and we can or a similar address. So there are multiple indices that we can review, and we will build that into a framework so staff know that while there's a care record that shares the life journey of a patient, there is also a major professional onus on our staff to use that resource appropriately, but there's also checks and balances for patients. Okay, next slide. Okay, that was a very quick run through, so that I was trying to leave us half an hour for questions, and I'm quite happy to take any questions.
Dermot, yes, there we've got Gary. There's no questions so far in the chat as of now. But there's a hand up.
Hi, Gary.
Hi, Dermot. Fantastic. And if we implement even a fraction of what you've described there to its fullest, I mean, health and social care will be a far better place for it all, as you know. Just a question, I think from a big picture standpoint, and how we can best support Encompass in the work that it's doing. At a headline level, I just made some quick notes there: statistics and planning, population health, R&D, and command centres. All things that have a regional focus, and myriad groups looking across those various areas. How do we support Encompass, and what, I guess it's too hard a question of what do you think the breakdown should be, but how do we stop fragmentation in those areas so we can get a consolidated view of and optimize all our resource use in some of those?
Yeah, look, thanks for that question, Gary. It's very prescient. I think that's not where we've succeeded as well. I think we've succeeded very well with the trusts because we were sitting with them, working with them, embedded with them, and I think the regional reach and as we've gone round, we've discovered the data outputs from each trust are called the same, but they're got in very different ways. So, part of our reset is to reset how we collect the data, I think we can only do that well if it's a partnership between obviously the trusts, Encompass, Epic, but it has to be a partnership with the Data Standards Board, the SPPG, the IAD, the PHA, and some things are called differently, and it's okay to call them differently. NHS England have agreed a data output for the EPIC implementations in England. They don't have in any other UK, and that's 11 large trusts, about 30% of the England population. There's an argument to say, do we want to have Northern Ireland unique, or do we want to have data that's immediately comparable? The benefit of comparable data to other EPIC implementations is that if they're doing something really well, we want to know about it and we want to bring it here. And if we're doing something really well, we can help them. So I think a lot of our data in the past has grown up organically. I don't think anybody sat and planned the data landscape that we currently have. It has just evolved. Now, I don't think it's our job to own that future, but we have to be part of the discussion around, delivering that.
Yeah. Dermot, even if I go and look at that, is exactly it. I think part of it will naturally mature as the Encompass implementation completes and then gets into the new stage. But if we look at something like population health, I know regional command centres are looking at population health. I know PHA is looking at population health. Encompass has a population health model. That institute's involved in population health modelling. And I guess at a intuitive level, rather than maybe an evidence-based level, or rational level, as you would say earlier, it's not linked in a way to get the best results, in my opinion. And I think part of what I'm seeing or hearing from you is that great development we're doing. We do need to maximize it, but we also need to make sure that the whole region is playing its role and not doing redundant work, standing on each other's toes, making sure everything feeds into a single valuable source. And that's kind of not a concern, but it's something I think as a region we should be looking at.
Yeah, part of this is done in a sequential way. We'll do this, we'll do this, we'll do that. So we've got 3 trusts gone live. In essence, we've thought we have to get into a business as usual situation, but that includes the data, the business as usual data, and we're only stepping through that. And I think the achievement of going live safely is not really an achievement. You have to do something meaningful with the platform, and you have to have those that can do something meaningful with the platform. So that's not necessarily the trusts. That's the PHA. That's the university. That's the research. So could we have evangelized it a bit better? Possibly. I don't think people know it until they see it and feel it. Certainly the universities can understand what their potential is, but they will be coming with the university hat and how to do that. And it's quite interesting. One of our partners is Manchester, and Queen's have a partnership with Manchester University anyway. So they're well versed on what they can do, because they're immediately thinking we're on the same platform doing the same thing. we can have a much bigger, maybe a 4 million population to do work together.
Darren, the potential's unbelievable, and look, the very best of luck in the upcoming go live, and I'm sure it'll be as successful as all the others. I think me, you, and Mick are catching up anyway in independent sector soon, and maybe we can see how DHCN and others, how we can help. I think bring to life some of this stuff for you.
Thanks for that, Gary. Much appreciated.
Yeah.
Done.
Dermot, I'll jump in if I can, just while there's an absence of hands or questions in the chat at the moment. Yeah. First of all, just thank you very much. Really good to spend a little bit of time today in Digital Dispatches, considering everything that you've presented. And what was really evident as you went through was the scale and the scope of the transformation that's available to us through the Encompass program, and by transformation, the change in the ways that we work and the way that we deliver care to drive improvement, to make things better. Transformation gets bandied about quite a lot, but fundamentally that's what it boils down to, right? To what was also really evident, I thought, throughout your presentation, was that's so much more than just a technology implementation. It is about cultural change. It's about changes to ways of working. It's about gaining buy-in. To expand some of the points that Gary's making there as well, it's beyond just the trust. It's a whole ecosystem. And you've talked within the last sort of half an hour, 40 minutes, about some of the principles that you've positively demanded from the program to be able to deliver that. I wonder if you could maybe just touch on at a practical level, I guess, how you've approached change management and business change within the program. It's been massive, and it's a bigger part of it as the technology is. And I think there's probably opportunities for other programs of transformation and change to look at how the Encompass programs approach things. Maybe take some lessons from that as well. So yeah, I wonder if you could just.
I think it was the standardization of care piece was really important. I had some past experience in that as a medical director, the Cancer Network. Everybody will standardize cancer care, but maybe not so much in other care. It was after COVID when the trusts were more used to working together as one cohesive group. So that was a benefit. I think the addendum allowed us to appoint professional leads from each trust. So when the conversation was about social care, it was being led by social care. It was being led by a social worker who knew something about children's social care, or somebody who knew about learning disability, and it was about peers agreeing with peers against best practice, whether it be nursing, and there's multiple different types of nursing, or there's been different types of medical specialties. It was really peers leading peers through this, enabled by digital. It wasn't sort of, oh, we need this the same because we're putting it on a pathway. It was what's best for your patient, and how do we ensure that everybody gets the best possible, whether you live in the middle of Tyrone or the centre of Belfast. And I think that was a driver. And I think I think peer-to-peer is a good way of doing it. And if they were stuck, we would say, well, why don't you go and see it? And we could always choose really good high-end centres to send people to if they were sort of recalcitrant or not so keen for change. The other thing is, you need champions for change. The super user process was there to get people to train people. But what in essence it did was you'd got people with high-end skills, knowledge, and who could talk to their colleagues over coffee. So you had 1 in 4 telling everybody about this thing that's going to happen. No other transformation has that kind of reach. And it's almost like it wasn't a deliberate, intentional thing, but the way it worked was that everybody knew about the process and everybody was knowledgeable, so they would go to training. And it is a major change because we're changing how they work clinically, and then we change how they work digitally. But to have that reach, and I mean, one of the last trusts to go live is the Southern Trust, and I thought there might be just sort of, people might just be worn down by the time we get through many go lives, and they got 2,600 super users, and I thought that's great. Then they come up with another 500, and so they've got 3,100 super users out of maybe total workforce of 10,000, and that's getting us up to 1 in 3 who's a champion for what we're doing. These people are not paid. These people are just doing this because they think is the good a new future, and I think without that depth and reach, it would not have been successful. Now we have people, we always have medical leaders, and we have nursing leaders who are full time in the program. But if you're seeing, I mean, I called out a number 205 posts, but there's literally thousands of super users behind that, and probably a total of 15,000 super users, and they're the people that drove this.
Thanks, Dermot.
Dermot,
Yeah,
we have.
really good.
Oh,
Sorry, go ahead.
apologies, Tom. Apologies, we're getting some questions in just through the chat. So we've got a question just interested in clinical trials. So what information will be available on clinical trials and patient participation generally? Will there be any data on trial and enrollment in time?
Yeah, we're setting up an academic group to do this, and we have obviously partners in our partners in the UK are major academic centres. It's Cambridge, King's, Guy's, Manchester. So they've all gone onto the Epic platform, possibly because of their academic backgrounds. So we're linking with them to see how they have done this work. The benefit of the trials is that all the information is in one place, but the patients know their own information, and we can communicate with patients if we want to enrol them through the MyChart app. This is actively being managed. It's not live yet because we want to get everybody on the platform first of all, so we can provide equity. But we're hoping that this will turbocharge research and patient engagement in research.
And then there was another question, Dermot. Are there any plans to bring Encompass to primary care in the longer term? This is from Aideen Johnson, who says her understanding that it's only a one-way access, and what are your views on this?
Yeah, the general practitioners weren't included in the original business case, and they sit on a separate platform. They do have access to read-only Epic Care Link. They can make some orders on it. They can make blood orders, and certainly they do make radiology orders on it. But it's not full integration. The GP landscape has changed a bit. Some of the providers have dropped out, and there's only one provider called EMIS now. They've been bought over by a company called Optum, who are one of the supporting companies in our programs. So we have quite a good working relationship. Epic don't really have a GP platform. I don't want to speculate whether they will have one in the future, and I think there will be contractual issues and monopoly issues. So I'm keeping well out of that. I do think the investment in everybody but GPs, it has been a problem, and I think we have to recognise that our GP colleagues probably are seeing huge investments in digital enablement elsewhere but themselves. And we have a GP advisory group, and I attend that myself, and I think we have to address that gulf, because if we start bringing on AI technology to improve the lives of professionals within secondary care and social care, we can't leave our GP colleagues behind. So while Encompass is a big thing in the landscape, I think some of this stuff has to be approached, as just one digital unit in Northern Ireland, because patients, the vast majority of care, 85–90% of care is given in general practice.
And then Dermot, another question. Someone said, hello and thanks for your talk. Can I ask about the ambient listening plans for Epic?
Yeah, ambient is under trial in one of our colleagues at present in the UK, and it's I was at a demonstration our Dutch colleagues use it, where they did the ambient discussion in English, and then they did it in Dutch, and then they got the ambient to translate it back to English. It's huge potential in that it means you have unstructured conversations, as say at an outpatient, and it populates the Epic platform, plus produces a report, and you can share that report, or you can share a report that's not full of medical jargon with the patient. I think how they've approached it in King's is that they're doing this on the basis that it makes them more productive at outpatients, and they want to do additional numbers at outpatients by using this technology. So while it will cost, there is a return in that cost. So we're very focused on how do we make outpatients more productive. Our outpatients perhaps at times have 2/3 of the outpatients are review patients, as opposed to new patients. And the problem in Northern Ireland is that new patients can't get in to be seen. So we talked about optimization once with the 5 trusts go live, and other trusts other implementations have approached this by going through doing the undone bits by the technical pieces that are undone, and our Danish colleagues advised us against that. They said you should choose 10 big things that will make a difference, 10 clinical things that will make a difference, and then build around that. And I'm very attracted. I mean, it's not my call, but I'm very attracted to something that says, let's make outpatient access better. Let's make day cases more productive and access better. Let's improve linkages with social care and social care placements. So, I mean, yeah, I think ambient has a huge place to play in that. It's pretty standard practice in parts of the US.
I think that is all the questions in the chat at the moment.
Okay.
I think that is, yeah, that is all the questions. I don't see any other hands going up there. So I think with that, we'll draw things to a close. Dermot, I just want to thank you for taking time out of what is an extremely busy schedule. I know there are go live readiness assessments happening this week, in fact today, ahead of the May go lives at Southern and Western Trust. So thank you very much for being so generous with your time. That's been really informative and good to understand the transformative potential, and also some of the approach to how that business change is being enabled. Thank you so much for presenting to us today.
Thank you very much. All the best. Have a nice weekend, everybody.
Yes,
Bye.
Thank you all for attending. See you all
Goodbye.
soon. Cheers. Bye-bye.
Thank you, Dermot. Good luck.